My name's Charlotte Gregory. I work as a clinical psychologist in the Central Norfolk Early Intervention team. And do you want to?
Yeah. My name's Hannah Cole. I'm a trainee clinical psychologist in the Early Intervention team.
And we work with people who are between the ages of 14 and 35 who are experiencing a first episode of psychosis.
Just one thing, can everybody hear all right? Or do you want a microphone?
Lovely. So we'll go on to tell you a little bit more about what we mean by psychosis and a little bit more about what we offer, but that's essentially our team. And we're based in Norwich, Central Norfolk, but there's also a team in the east and a team in the west.
No, it's all right. So what is psychosis? What actually is it? Which is one of the most common questions that we have. It's essentially an umbrella term for a range of symptoms which can be seen as quite unusual. People are maybe losing touch with reality in some way. So first of all, people could have unusual experiences. So that could be hearing, seeing, feeling, tasting, things that other people can't. So we might call these hallucinations, and the most common ones might be sort of voice hearing or seeing shadowy figures, seeing things that aren't really there. The voices can be pleasant, they can be unpleasant, and they might give you a sort of running commentary about your own thoughts or giving you commands to do things. That can be quite scary for people. It really depends on where they believe the thoughts have come from.
As Hannah said, it can be a real mixed bag. So they can be, often people might have a combination of pleasant and unpleasant voices. So it can be in really sort of two minds about whether they want help or support with them, because they don't want to lose the pleasant experiences along with the difficult ones. And then also people can have unusual ideas and beliefs, so sometimes those can arise out of the unusual experiences. For example, I would imagine if I was hearing a voice and I didn't really know where that was coming from, I might have some unusual ideas about where that came from. Is it somebody external communicating with me? Is there some kind of wider conspiracy going on? Those are the kinds of unusual beliefs that we often see people having in our service. And also unusual reactions and unusual behaviour. So by that we might mean things like people might be quite withdrawn, they might be quite agitated, they might be quite depressed, and they might have difficulties with their sleep. You often see people that perhaps sleep all through the day but are awake a lot through the night. And again, that's often in response to the unusual experiences and the unusual beliefs. I wouldn't say we see two people that are the same. There can be similarities, there can be themes, but no two people are the same. But it's just about trying to, when we meet with people, unpicking what their unusual experiences are, how they understand them. That's the question I ask most often, is what do you make sense of this? Where do you think it's coming from? Is it your thoughts? Do you think it's something else? There's something else going on? And often people can have quite confused thinking. Their thoughts might be quite jumbled up. They might have lots of thoughts kind of rushing through their head, and so it can be really difficult for them to communicate what's going on for them. So it's about sort of giving people a lot of time and space to just try and figure out how they can express what's going on in their mind.
Yeah, it's that.
So often we get people coming in and saying, is this a split personality? I don't know if you've made that connection before. Actually, psychosis and split personality are two completely different things. Split personality is often associated with something called multiple personality disorder, which is really, really unusual. Psychosis is not split personality. And also because it's got psycho in the term, lots of people say, sort of make connotations with psychopath, and it's completely different. Psychopathy and psychosis are completely different things. And often people talk about, well, is this schizophrenia, or what's the difference between psychosis and schizophrenia? I don't know if you want to say a bit.
Yeah, so we've got this up and running now, so this is essentially what we've said so far. The headings are the broad categories of symptoms and some examples in blue. Then some common questions, as Charlotte was saying. The last and probably the most common being, well, is it the same thing as schizophrenia? Does it mean that the person is going to become schizophrenic? What's that all about? And that is quite confusing. So schizophrenia is a kind of psychosis. It's a mental illness, but it has the psychotic symptoms, so everything on the last page, as its defining features. So it could be, though, that there are a range of other mental illnesses that also have some of those symptoms as a part of them. So it's not as clear-cut as to say, if you've got some symptoms, you've got schizophrenia. Does that kind of make sense? There's more to it than that.
And most of the people that we see on our service don't have a diagnosis of schizophrenia, and we won't give a diagnosis of schizophrenia. We talk much more in terms of psychosis because it's much more of a sort of broad term that is more helpful. And often, actually, diagnosis doesn't really explain what's going on for that person. It's, in my mind, and sometimes for people that label can be helpful, but it doesn't necessarily change what we're going to offer as a team as to whether we say, yes, it's schizophrenia, or actually, no, we're just saying it's psychosis.
So we would focus very much more on the symptoms than what we're going to call it. And as Charlotte says, yeah, it doesn't matter so much because we'll do the same thing either way. There's also quite a lot of stigma around the term schizophrenia. It's portrayed in the media as people being dangerous, so it's just all in all quite unhelpful. There's a lot of misconceptions. So again, another reason why we just tend to think about the symptoms, because it doesn't mean you're going to have a trajectory of having repeated psychotic episodes forever. It definitely doesn't mean that. Some stats said that about 45% of people will have one episode only and then go on to recover. Okay, so psychotic experiences, so everything on that first slide, are thought to be on a continuum with normal experiences. So it's not that there are people who are psychotic and people that aren't. We all share these experiences. Some people will barely notice them, others will have them to the extent that they really need severe mental health input and intensive mental health input. So symptoms of psychosis will usually occur in late adolescence or in your early 20s, and that's a stressful time of life. There's lots of transitions going on there, so that's when we most frequently see people coming through. And certainly in the early intervention service, that's the majority of our age range, of that kind of late adolescence. But the lifetime occurrence of somebody having a psychotic episode, so again, not schizophrenia, but a psychotic episode, is more common than having diabetes. So it's really much more common than you might think. Some symptoms of it are even more common than that, and they don't cause problems that would bring you into contact with mental health services. So that's people more on this end of the spectrum. So hearing voices, for example, that's 6 million people in the UK report hearing voices, so it's twice as common as having red hair. So that really might be quite a surprising statistic for people, that actually there's lots and lots of people hearing voices, maybe having unusual experiences, that definitely don't have schizophrenia and never come into contact with mental health services. So it really is a continuum, and I think that helps to reduce the stigma a little bit if we think of it like that. So several factors determine whether or not, sort of how you move along this spectrum, this continuum. So that might be people's reaction to the voices. Are they really distressed by them, or are they not really bothered? They just think, you know, if you're really sleep deprived, you might have had the experience where you thought you could hear something in the middle of the night. I know I've certainly had that. But I just thought, oh, as soon as I get a good night's sleep, that'll go away. Another factor might be how often they occur and how long they last. Obviously, there's lots of variation there. The impact it's having on a person's life. So has it occurred at the same time as sort of a real decline in functioning? Have they stopped being able to go to work? Are they withdrawing from having any social contact? So things like that would be, obviously we're getting to towards the end of needing some mental health support. How bizarre the experiences are. So lots of people might report maybe having seen ghosts or believing in quite spiritual things that might seem quite unusual, but they're not that bizarre culturally, so they go unnoticed, they don't ever need support. And also the meaning that people give to them. So how, as Charlotte was saying at the beginning, where do they explain that the voices are coming from? Do they think that they are inside their mind, or they're external? Do you think they're coming from the government or the TV programme? So that kind of meaning and explanation is really important too. This motley crew, so Vinnie Jones, what's her name again? Zoe Wanamaker. So I think she's in Harry Potter and My Family. Socrates on the right over there. Gandhi and Anthony Hopkins are all people that have said that they've heard voices in their lives. So just a few kind of famous examples of people that, yeah, as we say, are very much on this end of the continuum.
We do often talk with people that come into the service about this, and unfortunately we need some trendier examples. We do.
Try to vamp it up.
People I meet with say, oh, who's Vinnie Jones? I don't know.
Yeah.
Even though I want to make her, although she has been in Harry Potter, so that works quite well.
Yeah, that's true. Yes, we need some younger people. So what causes psychosis? So it can affect anyone, irrespective of gender, race, religion, anything like that. We tend to think of it in terms of a psychosocial model. And within those sort of broad areas, there's lots and lots of different reasons. And it's very much about the combination of these factors and how they work together that means that you could end up having a psychotic episode. There's no one cause, and it is very complex. So just some of those. Genetics, so there's a lot of evidence to say that family history means you're more likely to experience psychosis. Medical conditions, so things like epilepsy, or if you've got dementia or brain damage.
Yeah, and celiac as well as something.
Oh really?
Unusual experiences, yeah.
Drug use, so that links with sort of what the Matthew Project was saying, that maybe if there's something underlying anyway in your genetics and then you've taken lots of drugs, the sort of changes in your brain might mean you're more vulnerable to psychosis. Social factors have very strong links, particularly trauma. So trauma in early life, very strong links to psychosis. Stress generally, and bereavement, so a sort of a grief reaction can make you more likely to experience it. And then just up there, psychological, so your beliefs that you've grown up to have about yourself, about the world, about other people. If those are more suspicious, you can see that again on the continuum you might be more prone, with some other factors, to then end up in that middle bit, which is psychosis. And your coping behaviours and your emotions.
And we see a lot of people who actually are quite avoidant of talking about feelings, of talking about sort of what they might be struggling with. And I think there's certainly a sense that actually they sort of see all these things over, or kind of push these things away, and actually it kind of comes out, these difficult experiences or difficult feelings come out in other ways, perhaps through the experiences of voices. A number of people I've met with who might be having unusual experiences hearing voices, which they find difficult to think of as being linked with something that they're going through. It's too difficult to, this isn't always the case, but it's too difficult to sort of associate with something that they're thinking, so it's kind of externalised. Does that make sense?
Okay, and one way of thinking about this is what's called the stress vulnerability model. So if you imagine you've got, again on a continuum, a low level of stress up to a high level of stress, and then a low level of vulnerability for all those reasons that we talked about, that you could be vulnerable, your genetics, everything like that, up to a high level of vulnerability, you need enough of both or a lot of just one in order to become unwell. So if you look at the graph, if you had a very high vulnerability, but you never really had any massive stressors, so you didn't have any trauma, things were quite smooth, you may still be well throughout your whole life despite having maybe a parent or a grandparent with schizophrenia. And then on the other end of the spectrum, you could have a high level of stress and experience trauma, etc., but because you're not vulnerable, you don't have that in your genes, your temperament just isn't that way, you still are well and you never end up experiencing psychosis. So it's that kind of combination of both. Does that make sense? That sort of
There was a
way of
Beirut hostage called Brian Keenan, I don't know if you've heard of him, yeah. And he was placed in solitary confinement. He didn't have any experience of psychosis previously, but when he was placed in solitary confinement, he started having all kinds of really unusual experiences. And so you could think of him, I suppose, as being having a low vulnerability but extremely high level of stress, which just sort of tipped him over the edge.
So, treatment. Medication is sort of the kind of first line treatment when somebody's severely psychotic, but you would have a consultation with one of the psychiatrists in our team to discuss options. People's preferences will be taken into account as much as possible. You'd have to think about side effects and pros and cons of medication. The other thing to say about medication is that we need, what was his name, Steve, back in here, don't we, for this bit, but we'd get it up to a dose that was therapeutic level, and then maybe reduce it down to the smallest amount needed to stop the person from having symptoms, and then keep it at that level. Is that right?
Yeah. Or sometimes people might come off medication. Sometimes we get people that say, look, I really don't want to take it, can I try other options? And then we can also respect that. So,
yeah.
But yes, often medications.
So the next one, they're talking therapy. So this can be individual therapy, it can be CBT with one of our clinical psychologists. It could also be family work, so we do a lot of work with families, something called behavioural family therapy, which is all about how the family communicate and how communication skills have maybe got lost under all the pressure and distress of the illness. And we'll offer this at various different stages, so it might not be that as soon as somebody comes into service they're ready to start talking about their distress. It might be that they need things to just settle enough, then they can start to explore what it meant for them, how it's affected them, that sort of thing.
And we also run a friends and family group for people that want to kind of come and speak and meet other parents, siblings and partners, just to get a bit of support. We ran that for a little while where we were kind of giving lots of information to people, and whilst we still do that, actually what people said they wanted was they just wanted to meet each other and talk through how difficult things could be. So we did that. We just meet monthly now.
And then the last one, there's social recovery. So the early intervention teams are really focused on social recovery, and this is because if we can get people functioning well again, that means that their prognosis is much better in the long run. And these are things that start to slip when you're becoming unwell, so that might be your job or your education. It's just about getting all of that back on track slowly at the person's pace. And it might be that they start to do some voluntary work and build up skills ready to go back into full-time work. There's lots of occupational therapy support available in the team. And yeah, just to allow them to live an independent life again on the way to recovery.
Because often we see people where, the symptoms will reduce and they might not be having as many unusual experiences or as many much distress associated with unusual beliefs. But we also see people who continue to experience psychotic symptoms, but actually are managing really well. They're still able to study, they're still able to work. So just because you have those experiences doesn't mean that you're not able to do things that everybody else does.
And just then about the recovery of psychosis. So about 20% of people will continue to have problems which will affect them throughout their lives. About 35% will show a bit of a mixed pattern, so they'll have episodes on and off, but then long periods where they're not affected at all. And about 45%, as I said earlier, will recover after one episode, or maybe more, but they will make that sort of full recovery. And outcomes are certainly better if we can catch it early, so that's all about early intervention. When you start to see warning signs, we'd encourage you to refer to the team, at least for a consultation about if a referral would be appropriate, because again, if we can catch it early and start working with people early on, and as the teams improve and the understanding improves, obviously the recovery for people looks more promising. So, as carers, or if it's a friend or a family member, people often have a really difficult time with it. It can be really painful to watch somebody that you love going through something like this. And as you've seen from some of the symptoms, really scary, quite isolating experiences. So it's very common that carers do suffer as well. They might be confused, they might be angry, they'll have a whole range of emotions and experiences. And that's completely normal and completely understandable. So hence, groups and things where you can meet other people that are going through the same thing.
A number of family members I've had that have said to me that they've sort of apologised for sometimes feeling angry or sometimes feeling upset or worn out, and I just think, well, I completely understand that, because it's really hard work, and they're talking about a loved one that they care very much for, and actually seeing them go through something so distressing, but also feeling frustrated that they can't, either with themselves they can't do more, or actually that they can't really understand, or it feels like sometimes that their partner or son or daughter, maybe they could be doing more to help themselves, but because they're not always communicating with them so much about what's going on in their head, it's difficult for them to sort of fully comprehend what they can do, how they can support them, and I think it's just fair enough to sometimes feel burnt out or worn out.
Yeah, absolutely. And it's inevitable that they might be thinking, well, how on earth am I going to go on like this? I just can't see how I'm going to be able to cope with these problems and what's going to happen in the future. But actually, as easy as it is to say and as difficult as it is to do, it's probably going to be much more helpful for your relative or friend if you can manage to stay calm and to stay optimistic, because they will be quite easily upset themselves. They might find it difficult if they're being sort of fussed over, or they might find it difficult if you're becoming frustrated with them. So as much as possible, try to keep calm, and I realise that that's, going to be cold comfort, but that's sort of the advice, and I'm sure that gets easier over time, is that the carers' experiences that once they've got the information and they maybe realise what they need to do, it does start to become a little bit easier. Try not to take it personally if they say hurtful things to you, or if they seem to be behaving in a way that seems uncaring or preoccupied with themselves. That is all part of the illness, so they won't be you won't be communicating in the way that you were before the person became unwell. I think that's a given, really. So some sort of advice and what to do if this happens. Try not to spend all of your time together. You will need your own space because it will be have a big impact on your life. Be aware of what to do in a crisis. So if your friend or family member is already under the early intervention team, there will be a crisis plan in place. And depending on how much the young person has sort of opted to share, we can include you in care sort of on an individual basis as we go through. Obviously, we can't break confidentiality unless there's a good reason, but on the whole, we would try as hard as possible to include friends and family, because we know that those are the people that are there day in, day out.
Can I just ask, so
Yeah.
if somebody wants things to be confidential, can you still give broad guidance? to
Yes,
families?
absolutely, yeah.
What we do is I work with a sort of smaller sub-team. We call ourselves the Friends and Family Pathway Team. So if somebody comes into the service, they're allocated a care coordinator, and then I will have not met that young person, but say, well, can I contact the parents or partners and just give general information about the service, about psychosis. If parents have got, or partners have got any questions, I can pass those on to the care coordinator and sort of act as a bit of a mediator. I mean, the goal would be that we can encourage the young person to share as much as they can, but we know that that's not always possible early on.
Yeah. So you'd also have details presumably for the crisis team, so crisis resolution home treatment team, or your out of hours GP. So it's just important to know that if things did escalate, that you would know what to do and getting that information early on. Try not to either confirm or deny their experiences. So it might be quite tempting to say, oh, no, that's just not how it is. You know, there isn't anybody after you, or whatever the experience might be. But actually, it can be more helpful to just accept that you're seeing things differently rather than being at loggerheads about it. And try and focus on how they're feeling rather than on the individual beliefs that they might have. That way you can still support them without getting sort of wrapped up in the ins and outs of the delusion or the experiences. And try to maintain a balance. So offer practical support where you can, but also allow them to maintain their independence. Because it can be tempting when somebody is struggling like that, especially with their functioning, maybe with their hygiene, their sleep patterns, to just try and take over and just try to do things for somebody. But in the longer run, it will be more helpful if you allow them to do things themselves so they can gain confidence, get back to their own independence. And looking after yourself. So, as Charlotte said, it's not selfish to feel frustrated. It's not selfish to need a break from people, from friends or family members. It is important to talk to other people about how you're feeling. Keep doing things that you find relaxing, that you find enjoyable. Keep seeing relatives, keep seeing friends. That's going to be just as important for your loved one as being there for them, is to look after yourself. And sort of maintain a sense of hopelessness. So it might seem like they're having really severe difficulties, but there's a very good chance, as we said, that they will make a good recovery. I think this is getting there. And what if I'm not coping? So as a carer, if you're not feeling able to cope, we've already given some examples of the things available sort of within the NHS team, the early intervention team.
We've got some team leaflets which we'll leave out on the side, and we've got some of the normalising information if you want, about how common unusual experiences can be, which we'll also leave out.
Yeah.
And there's also Mind for care support groups.
Yeah, so there's a list up here of lots of different areas where you can seek support if you are struggling. But I think the first port of call, and we can also signpost, would be the early intervention team if the person that you're supporting was under the team.
So you can get a referral either through a GP, or you can people can self-refer, or you can just come to us and have a chat.
Yeah.
Can I just interject as well? If you wanted to go to a carers group, there's a carers group every Monday at Yarmouth, every Tuesday at Carlton Court in Lowestoft, and every Wednesday in Norwich at Helston Hospital in the boardroom.
So that's for anybody under any service? Or,
Any
yeah.
mental health issues, and that's right, me. You won't avoid me.
Brilliant. I think that's about it. Thank you very much.
Thank you.